Well, good afternoon, everyone, and thank you for joining us today. My name is Anton Gunn, and I'm an advisor to the Intersection. This is an initiative of the Robert Wood Johnson Foundation focused on leaders in advocacy and healthcare and how we're working together to build an anti-racist health system. The Intersection is a place to share resources, experiences, inspiration about this challenging but essential work. This is a community that encourages collaboration with others. It's a place to get real about what is working and what's not working, and to get strategic about your efforts. So please check out our website at meetattheintersection.org to access recordings of previous conversations that we had, resources from RWJF grantees, and short videos from equity leaders. It really is the place to be. There's also a podcast called The Intersection, where healthcare and anti-racism meet. This is available on all streaming platforms, so check it out when you get the opportunity. And if you have not signed up for the Intersection's LinkedIn page, please do so. You can connect with others, access interesting stories, stay up to date about future events and resources. Because for us, community is essential for everyone that's engaged in this work. Health equity work can be demanding, it can be isolating, but that's why we're here to help you to connect with like-minded individuals, to share your experiences and your wins. Now, I've personally worked in a wide variety of capacities as an advocate and as a state policymaker. I've also been a chief diversity officer for a health system. And given these various hats that I've worn, I know the importance of reporting the wins, not only to advance the initiatives and the projects that you're working on, but also to illustrate to your leadership team what impact you're having. Now, this needs to be done both internally and externally in the community. So to effectively communicate what you're accomplishing in any health equity initiative is inherently difficult. The metrics are sometimes hard to come by or even to quantify. It's often dependent upon where you work and how much buy-in you have from the leadership and the stakeholders at your organization that affects the level of reporting that you need. Some health equity efforts may take years to see noticeable changes, especially for organizations that may have a very small staff or a small budget. So opportunities to report your wins and discuss the outcomes may be limited or hard to do, and that is what our conversation is going to be about today. So today we have some healthcare advocates and leaders who want you to know how they help you successfully report out your measurable data and the impact of the efforts. So I got some great panelists joining me today, and this is going to be a great opportunity for you, no matter where you sit as an advocate or whether you sit inside of a health system or organization, how you can find some success in porting those things out. So we got some great partnerships today. So I want to talk about them, and I want to give you a chance to get to know these folks. So regardless of what stage you're at in your organization, you will always need this level of reporting. So be prepared to tune in, dial in, take some notes, and be prepared to capture what you need to be successful. But before I start, I want to do a little bit of housekeeping items. So I want you to add your questions into the chat. If you have questions during this conversation, we're going to record a podcast after today's panel based upon your questions, and we'll summarize some of the themes from the day in that podcast. That way you have a chance to check it out. And then also I want to let you know, we're going to do some breakouts. We will have some breakout sessions after the panel. So I hope you will stay for those breakout sessions. This is an opportunity to continue the discussion and meet other people who are doing the work. So if you plan to stay for the breakouts and you need to be in a room with an ASL interpreter, please send a private chat to event support. Again, I'll repeat, if you need an ASL interpreter for the breakouts, please send a private chat to event support. All right, let's get ourselves started today. It's going to be a great conversation. So I'm joined by a panel of experts, all of them from the Lone Star State of Texas, and they're dedicated to advancing anti-racist health systems through the use of data-driven strategies. We're honored to have them with us today. And first, I want to introduce Esperanza Galvan, who is the Vice President of Population Health Transformation at Harris Health System in Houston, where she's held various leadership roles for more than a decade. As a board certified cardiovascular nurse with more than 25 years of experience, Hope has a deep understanding of both inpatient and outpatient nursing care. In her current role, she continues to champion innovative solutions that address the root causes of health disparities, fostering healthier communities, and promoting health justice. We're also joined by Melanie McGuire. She's the Senior Director of Programs at the Houston Food Bank, overseeing programs in education, health, and economic mobility. She has more than 13 years of experience in community and coalition building, nonprofit management, disaster response, and programmatic design. Melanie has held executive roles at food banks in New Orleans and San Antonio and played a key role in establishing Louisiana's first hospital-based food bank. And Sharma is a professor of epidemiology and the founding director of the Center for Health Equity at UT Health Houston School of Public Health. She is a behavioral epidemiologist and a registered dietitian. Shreela is also a co-founder of Brighter Bites, a nationwide nonprofit dedicated to providing fresh produce and nutrition education to low-income children and their families. She serves as the co-lead of the Health Equity Collective, which is a systems coalition to improve care coordination for social determinants of health needs in the greater Houston region. Thank you all, panelists, for joining us today. I'm really looking forward to this conversation. So I want to jump right in, and Hope, I'm coming right to you first. I'm going to start with you because of your experience in spearheading equity initiatives, both internally within a hospital system and externally in the community. So when you're working on initiatives that don't always yield a quick win, how do you successfully report your progress to leadership and to external stakeholders?
Thank you. And first of all, thank you for the invitation to be here. This is a great community, a great opportunity to talk to so many others. You know, Anton, when you started talking about the work that the intersection does and what we're trying to do here today, you're correct. A lot of our work is about buy-in. It's about years. It takes years to do. And also, how do you show that success? But I want to go back a little bit to just say, you really have to start with, what does success look like for you as an organization, right? In healthcare, it's a lot of times it is about biometrics. It is about changes in A1C. It's about changes in blood pressure and what have you. But you know, you have to walk in with your partner and negotiate, what does success look like for both of us, right? If I'm going to be successful with biometrics as it relates to blood pressure or A1C, you know, does that mean something to my partner at the food bank? Does that mean something to my partner at the School of Public Health? So for us, when we talk about sharing the successes, it's work. You have to start with that at the very beginning. That's the end in sight, right? How you're going to be able to demonstrate success in this work. At Harris Health, if you know anything about Harris Health is a large organization. We have 2 community hospitals, 16 community centers, a surgical center, a dental center, homeless clinics. So we're huge. And so being able to show that what we're doing and the work that we're doing, success can be challenging sometimes. But we've worked through that, learning from our partners, both Melanie and Shreela and others that have guided us. So to answer your question, is the visibility that we have to think about and put in place, again, from the very beginning, not just the visibility that we want to demonstrate to our community, but really, what is our community asking of us? I'll give you a quick example to make it a little bit more tangible. So when we started the work of culinary medicine with Shreela and the Houston Food Bank with Melanie, you know, we talked to our community, right, to get what would you like to see in a culinary program. We talked to our dietitians. We talked to our partners. It's like, we're going to create this program. What would you like, right? Because everybody's into a little bit of, they want to know what's in it for me. So being able to put this program in place and then being able to say, okay, Shreela is interested in A1Cs. I'm interested in blood pressure. Melanie is interested in pounds of distribution. Whatever those measures are, we have to put them together, right? And create a dashboard. Then that's great that you have a dashboard, right? But then how are you actually flowing it out to your internal and your external partners, and the community? I know I said community separately, but that's intentional because I have the organization that I have to report out to. So we have monthly meetings by the department at a VP level and above, where you're expected to show these dashboards and express this information. But then my community partners, it's a little bit different, right? The work that they're doing and we're doing, show them that dashboard. Look, this is what we're doing with the pounds of foods that you're giving us. This is the A1C change. This is the blood pressure change. And then the community piece, you've asked us to be able to do this with our food prescription program, our culinary program, and then not only just tell them, but have a website, have a resource where they can go click a button and learn, like, oh, this is what it means to us. I mean, this is, oh, they are listening or they're not. So a lot of information there, Anton, but it really is an octopus, because you have to be able to share that success with different folks. Yeah.
Wow, thank you. Thank you. Fantastic. There's so much I'm gonna unpack. I'm gonna come back to that, but I'm gonna jump to Melanie right quick. Because Melanie, you have a unique vantage point because you worked at food banks in different states, which is really cool. So tell us, how has working collectively changed the way you approach your work, and in turn, how do you share progress with the community?
Yeah, I think it's really important that what Hope mentioned about really leaning into each other's strengths. I mean, when you're thinking about a community, you're looking at the assets that community brings. And here we have a health system, a research institution that can really help us think about the strategies we're employing and the impacts that those strategies have. And then community-based organizations are so critical because of the fact that many of these organizations are embedded in the community. And so oftentimes we hear folks trying to gauge insight from the community without actually being in the community. And I think that's such an important opportunity that community-based organizations can kind of lean into, is really thinking about in what ways can we do this organically, in thinking about the infrastructure that community has. And so that opportunity that community-based organizations don't have to do it all, and we can learn from each other, is really critical to thinking about how we move this work forward.
Well, fantastic. Thank you for sharing. And I'm gonna come back and we're gonna unpack a couple of things that related to that as well. But I'm gonna go to Dr. Sharma right away. You got a lot of experience working for and with different organizations. I want to ask you about the Health Equity Collective that you're a part of. Can you explain more about what is the Health Equity Collective and how does it work?
Yeah, and thank you again for the opportunity to share here and being alongside my wonderful colleagues that I get to work with almost on a daily basis. So the Health Equity Collective, just to take a step back, 6 years ago, actually in 2018, the Clinton Health Matters Initiative actually had work going on in the greater Houston region from 2013 to 2018 that really ignited a lot of the screening around social determinants of health among health systems. And this was a time, where we were just starting off as a country into thinking about how do we standardize screenings for social determinants of health, and why should healthcare own this, right? A lot of that sort of conversation was happening. And then in 2018, when the Clinton Health Matters Initiative sort of had a sunset, they tapped us on the shoulder and said, well, we've started this work, how can we move it forward? And that's how the Health Equity Collective was born. It's a systems coalition, and it's focused on how can we improve care coordination for social determinants of health in the greater Houston region. And so, we, just to give a little bit of a landscape, we have the Texas Medical Center, which is the largest medical center in the country. And, but we also concurrently have the Houston Paradox, where we have the best medical care, but struggle with the most health disparities as compared to other parts of the country. And so that paradox is primarily because a lot of these social and structural related disparities that exist. And so as we went on a listening tour across organizations in our region, and we had about 500 one-on-one listening sessions with Harris Health and Food Bank and others. It took us about a year to get through it. We found out that organizations were very excited and interested in the space of social determinants of health and recognize that they need to come together, right, to address the need. For example, if Harris Health wants to address food insecurity, then they have to partner with a community organization that provides those services, right? So the work lends itself to collaboration and partnership. However, the gap was that how do you come together and partner in a way that's meaningful for both? It's a win for all of the stakeholders involved. How do you ensure that community lived experience is guiding and centered in this work? And so we use in Health Equity Collective, we are now a 325 plus member organization. Wow. It's huge. And actually, Harris Health and the Houston Food Bank co-chair one of our work groups, the food security work group. We use a collective impact approach, which means that there's a shared agenda co-created by the different work groups. And the shared agenda is really critical, right? What's a win for all of us together? What is it that we can do together? So for example, the food insecurity work group said, we want to know more about how do we implement and scale and sustain food as medicine, food prescription type of programs. We're all doing it, but how can we come together to share best practices? And so that's sort of the work of the collective. And it grew from, small 80, we had 80 organizations when we started, and we're now over 325 organizations strong.
Wow, that's incredible. So much more to learn about. So I'm going to go back to you, Hope, and ask this question, because you're inside of a system, you have senior leadership, you got a CEO and a board and everybody else with hundreds of priorities that are important all across the board. So can you talk to us around about how you share your progress to leadership in the organization? That's one. And then part two, that what do you do if you set some goals and those goals are not delivering immediate results? And how are you communicating that to leadership and keeping them fully engaged and supportive of the work that you're doing? So share a little bit about that.
Yeah, sure. I just want to say to Dr. Sharma, with the Health Equity Collective, because we were part of that, she said 500 interviews, 500, it took a year to do. But when we first started the Health Equity Collective, Shreela, I don't know if you remember, it was like, well, what are they doing? And, what are they up to? Now is the Health Equity Collective part of this, because they did the due diligence of talking to the community members. So I just wanted to remind us of that, right? We went from what are they doing to, are they involved? So I think that's really important. So to answer your question, Anton, progress. I'm very fortunate at Harris Health that I have a very strong executive leadership that is very supportive of this work. We have 44% of our patients uninsured. So so imagine that. Our patient population, every single person I think that works here at Harris Health is working here for the mission. So we know that we have to be very creative on how we're trying to solve problems. And it's not just about the best prescriptions and procedures. So very fortunate, again, our CEO is like, he meets with our team on a monthly basis, so we can inform him about what are we doing in different non-medical drivers of health, whether we're giving him an update in our Center for Accelerating Health Equity, or we're giving him an update on our food prescription, we're giving him an update on our medical legal practice. Like, it's meeting with him on a monthly basis. Then we have also, how do we show progress, is we have another standing meeting that gives us the opportunity to do the same, which is a VP and above meeting, because then it trickles from there. Because again, 16 clinics, 2 hospitals, dental center, huge. At that meeting, we're also offered the opportunity that our chief of staff gives us to be able to bring the updates there. Hey, last month we had 4 food pharmacies. We're expanding to 3. We're in December, we're on track. And so they're there to be able to block and tackle for us as well, because again, we're so huge. And so from the leadership side, it's those kind of platforms. Also, too, we have another opportunity through a DEI committee that meets on a monthly basis to ask about these programs that are in place right now. Whether again, you know, food insecurity, transportation, community health workers doing home visits, all the different areas that we are helping to address the non-medical drivers of health. We're given different platforms. Now, mind you, they don't just tell us show up. Like, we have a calendar that says you're going to report in January, you're going to report in March. So we know what to expect and come in with our data, come in with our current state. How do you show progress? That is really in a collaborative effort. I am very fortunate to work with Dr. Sharma and people like Melanie who can help me show that progress, right? Because again, I'm a healthcare institution. For me, if I'm going to show success, I'm going to say, oh, there's been a 1% change in hemoglobin A1C. But for Melanie, it may be hope. Your organization has given out 1 million pounds of food. You've served 5,000 families. And when you hear it like that from a partner, it's like, oh, wait a minute. So if I'm not necessarily showing that A1C change right now, in collaboration with my partner, who's very excited about all of these other things that we are doing together, you present that to your leadership and it starts to make sense outside of us doctors and nurses who are just thinking about one piece. So that's what I've been able to do here. And then one last thing is really sometimes when I'm not able to do that is just that low hanging fruit. What is that one success that I accomplished this week, right? So for instance, we have a model for food pharmacies, right? We have food pharmacies at different locations throughout our community health centers. I don't have sites in some places for a food pharmacy. And my executive leadership may say, but we want them at these sites. Well, I partner with somebody who says, you know what, food lockers, 365 days a year, 7 days a week, blah, 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 hope we can help you. I take that back and it's like, look, we have no space, but here's what we do have. Now, and you sell it by now, imagine this. Now we open ourselves up to greater access. So it's being very creative. And again, being in a safety net, we're 44% uninsured. We've kind of learned to do that. And I think in a big city of Houston, I think we've all learned that, how to be creative with the resources and the support that we have.
Fantastic. Oh, thank you for sharing. So, Melanie, I want to ask you how, from your vantage point as a food bank in the community, how do you quantify and report the success of your partnership with Hope Health or the collaborative? So, what are you looking for in terms of metrics, and then how do you report that as a success, or what the challenges might be?
Yeah, I mean, I think I can't underestimate the opportunity of the qualitative data. So what we understand is moving the needle on A1C is a journey, right? Particularly with populations where we're seeing such elevated rates of health conditions that improvement just takes time. And so what we've learned, though, through some of the qualitative analysis is that these type of innovative partnerships have long-lasting impacts on not just maybe those biometrics, but also things like, is the patient likely to come back to visit their healthcare provider from a preventative standpoint, as opposed to, you know, at a critical point where they're in a kind of pretty desperate situation. We understand that these type of opportunities improve quality of life. So we really double down on opportunities that we can better understand in what ways these type of partnerships really improve things like access to nutritious food, you know, help offset financial expenses that someone may have when they're able to redeem benefits for nutritious food at their local healthcare provider. You know, that money then goes to kind of basic needs, things like rent and utilities and other things that may be competing priorities for someone that is experiencing food insecurity. And then I will finally say that it's been a great opportunity to be able to see the impact on the healthcare metrics. So we specifically, from a community-based organization approach, look at the idea around utilization. We feel that utilization is a really key component to understanding the impact around health outcomes. And so it's not simply enough to just be able to send someone a referral to a community-based organization if we don't understand if they're able to access those services. And so through the opportunity with data, we're able to meet with healthcare providers on a quarterly basis and understand utilization and talk about utilization. And if we're disproportionately not seeing patients redeeming, then we can ask those questions why. And healthcare providers have really great resources to be able to reach out to patients. And then also, through the incorporation of wraparound services, as we talked about, like culinary medicine, it's a touch point to be able to potentially increase that utilization, which we know seems to have a correlation around health outcomes.
Very good. And so I just heard, early on, Hope talking about monthly meetings, internal to report metrics. You're meeting quarterly on numbers. So, Dr. Sharma, I want to ask a question. When you said 500 interviews, I think that not only blew my mind, it blew a lot of people's mind on here. And so that's a lot. So could you give us a little color around were those individual interviews or organizational interviews? And now that you've done them and you've got traction and commitment and buy-in, who do you report results to, and what's been the reaction to those results? Do you report them internally to your institution and to the community? So give us a little context and color around that as well.
Yeah, happy to. But before I jump into answering, can I share a story with my wonderful colleagues here? So we actually have a community advisory group of moms who have participated and produced prescription programs. And we put this community advisory group to just inform us about their experience and how is it that they like to receive these services. So just Friday, we had our meeting, end of the year meeting with these moms. And they don't know the story, but it just struck to me as they were talking. So this mom, she shared with us that she's never seen her hemoglobin A1C in single digits in a long time. Her A1C has always been in double digits. She's a Harris Health patient. And ever since she has enrolled in the Produce prescription program and the culinary medicine classes that she's received, for the first time in her life, her A1Cs are now in single digits.
Wow.
And just to share, she was in tears when she was sharing this because she had been struggling for a long time to manage her medical condition. So all this to say that the power of partnership and collaboration directly to serve families who need it the most, right? So bragging on my colleagues' work here for a minute. But jumping into your question, I'm an academic. I work in an academic institution, and I'll be honest with you. When I went to our dean and I said, we really need to invest in this systems coalition for care coordination. He said, say more. I'm not sure that that's our place to be doing coalition related work, but what does that look like? And so I shared with him that, some of the data that we had in regards to the food prescription programs, you can have a great program, a program that's proven to be effective in a randomized controlled trial, reducing A1Cs. But if nobody participates in it, it's not going to have the impact desired. And what we were seeing is that about half of those who were referred to these programs were actually participating in it, right? And that begs the question as to why is that? And so sharing that data, that this is an important research question from an implementation science perspective as well, right? And it has real world implications. And we have partnerships. We are a school of public health. Our work is with the public and for the public, and in partnership with health systems and community organizations. And so, and he said, this makes a lot of sense. Go forth and do this work, and we'll see kind of how it happens. But I think part of it I've realized, one is continuously educating our academic leadership and scientists in terms of what are the scientific questions that we are able to ask and move the work forward. And probably most importantly, the community being involved in not just informing the science, but being at the driver's seat in what are the questions that they want us to work on, right? And so that's the strategy that we have used with building these community advisory groups and really building community voice. But it has really required a lot of, I would say, continuing education with our leadership, presenting the data, and then being very transparent, right? If, for example, if as part of research is writing grants, but we want to be very transparent in what becomes a research question, right? You don't want to use the community to funnel your research agenda. You want the research to help answer the questions that the community wants you to answer, right? So really building that transparency into how we operate, making sure that every stakeholder is aware of it and has buy-in and is able to, the Health Equity Collective really also gives us the space to question each other in terms of, what is it and how are we approaching this work, right? Sometimes it's less about what and more about the how. And so I think that's a lot of sort of the piece that I find myself straddling is really educating our leadership. And I've been very, very fortunate that our leadership has been very open, similar to, what Harris Health Chair and Brian Green at the Houston Food Bank, just really that leadership buy-in is really critical, but it's a two-way street. You have to be in front of them all the time. And then I have not hesitated to also ask them for financial commitment towards this work. I think that's critical as well. You don't get what you don't ask for. And so, ensuring that I understand that these investments are infrastructure investments on which then you can layer health equity efforts on. Your programs and interventions will be that much stronger if you invest in this health equity infrastructure. So that's kind of how I've continued this work.
Yeah. So I got a couple more things to say, but I want to say you said one thing that was really important to me. I remember an experience with an academic health system where there were a lot of researchers attached to it, and they would go into the community to do all of this research, right? And I had community members tell me, I'm still waiting for them to come and tell us the research that they did 10 years ago. They come to our community, use us to get, research dollars and to do research. And I'm still waiting for somebody to report the win. And I remember this pastor saying, I don't know whether we're doing well or doing bad, but I know they keep coming back and doing research and we don't have any results. So it is a challenge. So I'm going to do something real quick and we're going to come back to this conversation in a second. I want to ask a poll question for our attendees to know whether you will stay for the breakout groups. This is really important for us. They will end by 2:30 Eastern time, and we want everybody to stay if you can and share with your peers and have a sense of success in this work. But we want to have a good idea of how many breakout groups we need to establish. So please to answer the poll if you plan to stay for the breakout groups. Just answer the question once and then we'll go from there. And so while everybody's answering the poll, I want to ask a question particularly to you, Hope. And I'm gonna just be honest and say it in my way. So when you work at a large organization like a large health system, it's a massive cruise ship. It doesn't turn very fast. You can't shift on a dime. You can't make things happen. So my question for you is really around setting expectations, and if health equity is not a priority or not a big focus, and what would you suggest as a strategy to stay visible, to ensure that your contributions and work are recognized in an organization that is big and moving in one direction, but may not necessarily come in another direction? Give me your thoughts on that.
Yeah, sure. So, I'm again very fortunate to work at Harris Health because health equity is part of our strategic plan, right?
Okay, great.
And you've heard multiple people talk about the leadership, the senior leadership that has to be engaged here. So I get your question. I think from my perspective, what I have found, because again, I'm a nurse. I am not a community person. I spent most of my time at the bedside, really dealing with patients who, again, working at some of the best organizations where we were giving the best prescriptions, doing the best procedures, but yet these patients were coming back into the emergency room, back into the hospital. And when you ask them, what happened? Why are you here? Well, I couldn't afford my medicine. I didn't have transportation. I didn't, all of these things. So, but what I found that just in learning and talking to my patients and just learning from other folks kind of already doing programs that were tackling some of these issues and some who were not, was that they have an interest. My strongest partners have an interest. It's like, Hope, we've got to find a way to do this better. You have to be able to find that key partner that will help you. It can't be just Hope saying, oh, it's the right thing to do, right? But if when I'm in these situations, like I will go pull my quality partner, right, to say, tell me what's your biggest heartburn. And they're like, Hope, we have, this kind of readmission, blah, blah, blah. Okay, what have you done? We've trained people, we've provided the best education, and we're still here. Well, then let's talk, right? Because we are now, okay, well, now we are screening for the social determinants of health, right? Which there's very few, I love that, because that information will not only inform us as an organization, it's going to inform our community, and it's going to inform our community-based organizations that can really partner with us on this. So I'll tell you, Anton, to answer your question, what I have found that worked for me is really working with someone who's already facing a difficulty that they've tried to work on, and they're not moving it. But you put two great minds together, and I'm not saying mine's a great mind, I'm just saying a mind, right? And you can come up with something that then you have data, right? The quality data in healthcare, of course, is, so important in our day-to-day. But then when I start asking, who are these folks? They're coming in. What age are they? And what race are they? What's their primary language? Because great that you did this patient education initiative, but you made it for the wrong patient population using the wrong language. And that's why I'm just giving you an example. That's why you're not successful. But I have found through the years that really taking that approach in working with someone who already has an interest, Antoine, because we're all trying to keep hospitals up, clinics up, patient, throughput fast, staffing, operations. But when I come in and I'm able to think about it from the, sort of clinical lens, but also from the community lens, and also from the health equity, and just inform them, a lot of times they're like, okay, how do we do this better? How can we work on this together? So you get that buy-in, and then you have to have a solution before you take it up to your one up. It can't be just, this is the right thing to do. So I think we did that with Food RX. Yeah.
Very good. So let me ask one more thing to you about setting expectations. Like, some of these things are big and complicated. And when you're engaging externally, what do you do to set expectations that this is the long journey and not the short journey? Because everybody wants an ROI. Everybody's asking for an ROI and want to measure an ROI. And, I've seen healthcare leaders quit on something because it's not an ROI. Even if it's in the strategic plan is not a 40-year plan. It's a 5-year plan or a 3-year plan. And so if they don't see ROI, in the first 2 or 3 years, they're ready to abandon it. So talk a little bit about how you all set expectations for what success looks like and process outcomes versus just, numbers-based outcomes.
Yeah, I think what's helped us is being very intentional in who we partner with and have agreements with, right, in our work, like a memorandum of understanding, a business agreement with the Houston Food Bank. I'll tell you what, we had never done that work. And at that time, the Houston Food Bank was also going through their journey. It's like, how do we work together that says, I mean what I say when I say, you're good at food distribution, I think I'm pretty good at healthcare. We put these things together and we commit to this. So it was putting and it wasn't easy. And so for everybody out there, this was not easy. It was a challenge for a couple of years because they're used to working with community-based organizations, not with healthcare systems. And I'm used to working with other healthcare systems and not necessarily with something like that. And then, so it's a challenge. It was a challenge but it was a show of commitment, right? That we're serious about this. And I want to go back a little bit too. When I go back to our senior leaders, I remember bringing in the Houston Food Bank and meeting our CEO at that time, and we all just sat there and we committed. So
Wow.
that was huge. It wasn't Hope Galvan over here by herself working with Melanie or somebody else, right? It was bringing them to the table, all of us together. And I'll say the same for UT with Dr. Sharma. We have a scope of work. That scope of work is shared during our monthly pop health meetings or whatever to say, okay, this is what we're committing to, right? We're on a path here, on a road, but at the end, this is what you're going to see. And so I think having sometimes that black and white helps a lot of the executives, where it's not just okay, great, Hope. It feels great for you and the work that you're doing, but and the day-to-day does not get impacted by that work. So yeah.
There's nothing better than when you sign on a dotted line that everybody's clear about what's expected and what's next. Melanie, I'm going to ask you about that. You're working with a health system. Again, she just set it up that she's working with other health systems and not really the community. You spend your partnerships primarily in the community. So how do you prioritize, or really how do you communicate how you decide your priorities amongst the different voices and share that with the health system? So give me some sense of your side of the house when it comes to partnering with something like a big health system.
Yeah, I mean, I think Hope's correct. It is a journey. And one of the challenges for community-based organizations is oftentimes we are hearing from different health systems, and they're at a different place in their journey. So one, I just want to highlight, there's a win for everyone here, right? And so part of the work we do within the Health Equity Collective is, how do we uplift learning? So whether it's, hey, there's this mandate around screening, how do we do screening effectively? How do we understand stigma and why someone may not be choosing to avail their information to a healthcare system around, basic needs or needing assistance? And how can we, help to encourage and provide toolkits and opportunities to really educate providers as we think about this holistically? And so I do think that, not everyone's going to be a Harris Health, and that's okay. I think one of the things that we know is community-based organizations post the pandemic are thinking about infrastructure. And there's oftentimes this scarcity mindset around, if we embark on this work, how can we do it so that we don't lose the trust of community, right? And because community-based organizations are so embedded in the community, that there's this real opportunity to think less from a scarcity mindset and more from an abundance. What do health systems and what does this opportunity bring to community-based organization? A great example of that would be, as we're thinking about where we're disproportionately seeing gaps in services, specifically around food insecurity, Harris Health and us have been exploring how can we think about scale in a way that's sustainable? And so we think about all of these locations where there may be faith-based organizations providing charitable food assistance. And oftentimes the number one thing we hear about is the concern around the lack of volunteers. And so it's not from a perspective of they don't want to do more, it's they just don't know the capacity. Most of these individuals are not paid individuals. They're doing this because they are from the community. And so then how do we build trust between healthcare systems and community-based organizations and faith-based organizations to embed services already in the environment? And so we're testing that work out now, where we have the idea around healthcare professionals embedding in the charitable food sector environment to, one, help alleviate the pressure for these organizations and their volunteer challenges, but also two, to help create better trust and connection, because oftentimes what we have learned in this journey through the Health Equity Collective, there's a lot of trust building to be had, right? In some of these communities, there's been a lot of distrust. And so healthcare is not always the first thing someone will access, but their basic needs are like food, maybe. And so I think those are great examples of ways to think about innovative approaches as you think about prioritization, and that there's really an opportunity to kind of bridge that partnership. Another great example of that, as Dr. Sharma talked about with the work around pregnant mothers, is, in that example in our project, the food bank was challenged around, okay, absolutely, we want a way to, home deliver food to individuals that, are high-risk pregnant mothers. However, we don't simply just have staffing to do, home deliveries at that scale. So we were able to bring a private partnership in through some work to be able to scale that model. And so this is a great example of ways in which community-based organizations, healthcare systems, and private partnerships and education institutions can all be working together instead of kind of solving that in isolation.
Yeah.
Anton, can I just add really quick?
Yeah, go ahead.
From the community side, as a nurse, so our C-suite goes out into community town halls, and they're there in their after hours, right, listening to the community. But it was really insightful what I heard the other day at one of our listening sessions that we hold at one of our, it's a theater district, but it's in the underserved neighborhood. And so we were having a listening session, and because the hospital, LBJ, has been so active in the community just by showing up, the community member said, what we're learning about you all, Harris Health, is that you all are coming out into the community and we ask for something, and in some form it shows up in a response, and then we hear about it again. That helped me, Anton, because as a nurse, I was scared of this work at the very beginning, because I was like, oh my God, I'm going to go out there and they're just going to ask me for everything, and I'm just going to have to answer to everything. Like they're going to want me to solve everything. And no, they just want to be heard. You do something with what you've heard and then just bring it back to them. So I just want to, echo what Melanie was saying. And that's what I've seen firsthand as of the last couple of weeks too.
Very good. This is great. So, Dr. Sharma, I'm going to go to you, but I'm going to talk a little bit about the underbelly side of this. And what do I mean, the underbelly side? John Maxwell is a leadership advisor. He's written a bunch of books, and he has a book called Sometimes You Win and Sometimes You Learn. You never lose. And so, to me, the learning comes from the outcomes that are not as positive as others, or sometimes they might even be negative. So could you give some advice for anyone who's watching, who's trying to make progress, and maybe they have results that are negative rather than positive? What advice would you give them about sharing it? And then I want to hear from both Hope and Melanie on the same thing. How do you share when you're not winning as much as you want to be winning, and what does that look like?
Yeah, and that sometimes happens more often than you would think or like to, right? I think, and something I just want to also echo, what you've heard consistently from Hope and Melanie is that a lot of this work happens at the speed of trust, right? And so we cannot emphasize enough that the time and the caring that you're investing in the community, and in your partnerships as well, is really critical to doing this work on a long-standing basis. If you're going to be in and out, that's you shouldn't be in this space. But otherwise, if you really want to do this work the right way, that investment in building trust is critical. It's foundational. Cannot emphasize enough. And going to your question, I think the bottom line is that this is not a linear straight path, right? And if you're going in saying, oh, collaboration, as long as it's on my terms, it's never going to work. And so I really liked how you framed it, that there's a lot of learning to be had. And in fact, that the learning is what's going to bring you to the solution that's going to sustain and work, right? You might have had, we all love our logic models. You might have had a great logic model to start with the outcome intended and the path intended. But as you go, I think, expecting that you are going to have bends and curves in the road, they're not stop signs. They're just bends and curves. And you're just learning how to navigate those. I mean, many times, I cannot tell you the number of times I've picked up the phone at 7 p.m. and called Hope and said, hey, what does this look like for her organization? We are thinking about it this way. And she'll say, that's not the way that's going to work for us. However, we want this to work. but this is what we, it looks like from our end. So I think that is critical information, right? If I'm going to wear blinders and sit in my ivory tower, that's not going to be impactful in any shape or form. And so to us, doing public health, and if anything, the pandemic has taught us, one, it's taught us the importance of communication, trust, transparency, and building the right collaborations using those three foundational standards. And so that's kind of how we have, operated and approached our work.
Great. Melanie, how about you? What do you do when it's not going well?
Yeah, I think it's really important to remind ourselves that much of this is really rooted in systemic policies. And so oftentimes community-based organizations come in with this approach that we are going to fix, and so when the outcomes are not as desirable, I think part of it's just to remind ourselves that, inherently we are working within systems. And so a lot of the work around the Health Equity Committee allows us to talk about the system level approach, right? And so, a great example of that is, around the work around screening for food insecurity, right? We've made some great progress with healthcare here in Texas. However, Texas has not expanded Medicaid, so it oftentimes means that individuals cannot have basic access to care. Screening is, while everyone's at a different place within their screening, so some healthcare systems have adopted this work and said this is critical to our organization holistically, and have really taken operational dollars and made huge commitments around investment, both to community-based organizations and to the work that they're embedding in their healthcare systems, but not everyone is there. And I think it's really important to understand and most importantly, uplift where we are seeing inequities. And that sometimes that does not necessarily mean that a project is not successful, but that we're just not there yet. And also, I think it's the tension that we face around prioritization. So, one of the projects we're working on right now is around closed loop referral work. And we're learning a lot about, how do we integrate this into systems? I think there's always an intention, what we heard from healthcare systems is we want to be able to screen, we just don't know what to do with it once we screen. But then there's also this next step of how do we embed this into systems so that it really doesn't take away from the standard of care. And there's some tension, underlying tension that exists there. And so that's what I always keep in mind as we think about this is, I'm working within a system. And that system and those policies need to be challenged. And then I think the infrastructure, building infrastructure, I can't emphasize how great of a win that needs to be. Oftentimes we try to pilot our way out of this work and we have these really great pilots, but in what ways can institutions invest in the food system as a whole? I think are things that we still need to be actively having conversations.
Awesome. So thank you very much. Hope, how about you close us out with your thoughts around how to report the negatives and talk about the negatives and the learnings from those experiences.
Yeah. So first of all, I don't use the word pilot. I don't like it. I use phase 1, phase 2, or we phase it out. Because pilot just means you can go away at any time. I think from my perspective, a couple of years ago, we tried utility vulnerability work. It wasn't the time. We did the right things. We talked to our partners, we talked to our community. It didn't work. I'm a firm believer about timing, but I think that showing why it didn't work is just as important as why it did it work, right? Because you learn everything. You're spot on, Anton. You have to learn even from the failures. So fast forward several years, I can tell anybody, we tried utility vulnerability. At that time, we didn't have the data collection. At that time, the partners were screaming for the data. We didn't have it, but we do now. Now we're screening for those non-medical drivers of health in the inpatient side. And look at the data I'm getting. What I was missing back then, I have now. So you got to think about those things. That's why it's important to publish even the failures, because you learn from them and never lose sight. What I hear all the time, Hope, we tried that. It's like, okay, but that was 5 years ago. That was 2 years ago. This is what I have now that can make, hopefully it'll be successful. And again, phase 1, phase 2, or phase out. So
That's awesome. And that's a fantastic last word, because I really could talk to you all day about this, but it's time to transition to the breakouts. And I want to thank Hope, Melanie, and Shreela for being here and sharing their insights. As you can see, they're doing incredible work together. For all of you who are on, we want you to stay connected with the intersection. So sign up for updates at meetattheintersection.org. Please follow our LinkedIn page. Also subscribe to the podcast. It's on Apple, Spotify, Amazon, or wherever else you listen to your podcast. And we really invite you to stay on for the breakout groups. If you can't stay on, it's okay. I know some of you can't. We appreciate you exiting promptly so we know how many breakout groups participants to expect, and we'll set them up. And we're going to start our transition to breakout groups in a moment. And I want to thank everybody for being here at the intersection. Thank you.